Just a moment. Okay, so it looks like it is recording. So Ashley, thanks so much for that reminder. So if you are listening in on the recording now, we have just gone through and done a welcome and introduction, talked about the overview of recapping the forum event, introducing the summary, and then going into our discussion for next steps in summary. So appreciate you guys joining and for listening in for those who weren't able to attend. So the forum participants, this is one of those areas that I really wanted to highlight to show the diversity of the disciplines and the different settings that were all engaged. So again, we had our convening organizations of IDPH, which consisted of both the State Office of Rural Health, but then also the Office of Primary Care, again, kind of a two-prong approach, and the Iowa Healthcare Collaborative. And we may have been the ones hosting it, but this was really an equal participative event, and so you'll see the spectrum of who we had engaged there. We had societies there, whether they were professional societies or they were organizations such as the American Cancer Society that, to be honest, many of us may not be as familiar with working with when we looked at rural health. We had our local critical access hospitals represented. We had the Iowa Department of Transportation. We had aging services represented, our allied health professionals through EMS and pharmacy. We also had our FQHCs that have a rural presence, not only through the rural health clinics, but also through those FQHCs, and then local public health, as well as an academic presence with the University of Iowa. And of course, we had Mercy and Unity Point there with a lot of their rural affiliates and having that stamp on our rural communities and being part of that landscape. So that's just a highlight that we have in through here. Of course, you guys saw who else was in the room with us. And again, when we look at this, one of the things that we will talk about is knowing that this isn't everybody that should have been there. And so when we look at those different pieces, is thinking in our heads as we look to move this forward and as we go through the summary, who were some of those other folks that maybe could be involved at the table or that we could be carrying this message out and be collaborating with. So just a quick recap of the forum, I'm not going to spend too much time on it. Again, just a reminder for those that were there, or maybe for some of you guys that weren't able to be there and this is your first join. We had a welcome, we had a setting the stage. So we spent the first day together in a large group, just kind of coming together and being on the same page about what we were talking about, what our intentions were. And then we looked at a rural health case scenario. So we used the rural implications of the opioid epidemic to really exemplify and kind of put into a tangible mechanism what we were going to be talking about and the importance of rural health. Then we broke into our small discussion groups and we started storyboarding. So this is where we broke ourselves into 3 different groups and kind of separated and really got to dive into some conversation again about what is rural health, what does it look like, what do we want to do around rural health to improve it in Iowa. And that second day is where we came back from that first day of kind of sense making and discussion and really honed in around what are our priorities. What are our top recommendations and what could we do around that? It was also day 2 where we all kind of did that report out and really that's what formalized into the summary. So we took the feedback from that first day and then from the discussion groups and really streamlined and looked at what the themes were, what are some of those common priorities, and then what were those recommendations. So again, when we look at forming the basis, again, this is just a quick recap. I'm not going to spend too much time on this. The recording will be available to everyone, as will the slide deck, so it will kind of filter in with that. But I just wanted to make sure that we captured what was included within setting the stage. Again, making sure that we talked about the rural health care nationally and what that currently looks like, what's the current landscape, rural health strategies that will influence us, including CMS and others around federal policy. And then our rural health case scenario, again, looking at those unique challenges and the community-wide impact of rural health. And our small groups, again, diverse settings, facilitated conversation, and we really focused it around those 5 W's and the how of rural health. And then we had the opportunity to report out and to have our state leadership respond back to us and continue to inform those conversations. And that included Dr. Tom Evans of IHC, Garrett Claybaugh, Director of the Department of Public Health, and now also the Interim Director of Human Services, And then we also had Keith Mueller and Chris Atchison, kind of that really robust conversation that we integrated throughout. And just quick recap, when we looked at this at the discussion again, it was facilitated around those the five W's and that how. So we asked, what is rural? What is rural health? How are those things different? How do they align? What does rural health look like today? How do we envision it for tomorrow? What is needed both to sustain what we have and to improve? What's currently being done around that? And where do we go? So again, that just frames up when we go through our summary, highlights the conversation and how we kind of progress through the days. So the discussion, again, the definitions of rural and rural health, some of the common themes that we saw within that are the fact that they're defined by a sense of community. It's characterized by sparse population, agricultural landscape, and geographical isolation, various interpretations of rural, limited resources, access, and choice, and a system of microsystems. Again, that was one of those key parts, especially for my group, that we talked about, that again, when we talked about the need for how we address things to be a systematic approach, was really the opportunity that it is a network of little mini systems that integrate in and within each other. So it's not only going to be one large rural health system, it's going to be smaller pieces that integrate within that, whether it be within one hospital system and how they integrate with another, whether it be local public health and those pieces that come in. So I know my group particularly, that was something that stood out to me, especially when we talked about what does community mean, how does that fit in? And we acknowledge that it's in transition, that it's part of this learning curve, that it's not the same rural health that it has been 50 years ago, and it's not the same rural health system that it's going to be in 50 years. But how do we acknowledge where we are and the steps over the next courses of years to decades to meet our needs now, but then also to build towards the future. And as we go through and we look at the summary document that you guys have in front of you, you'll see as we kind of lay through these different pieces that everything is set up to follow through and lead you through those pieces of discussion. We also had those assets and attributes in those discussions. So some of those pieces that came into play and say, what is existing? What is so great about rural health? What do we have currently? We have strong natural support. So again, that community infrastructure, that feeling of community, of being part of rural. We acknowledge that healthcare in the hospital is the hub of the community. It is oftentimes the primary employer in a lot of our counties. And so it's also involved in the integration and coordination of services. But I think it's also something really cool to acknowledge in a lot of the discussion that we talked about was also as the hub of the community, the intention and the expectation of a lot of our hospitals and our healthcare systems is that they're not just this locus of healthcare access, but that community integration. They're actively involved in their community beyond just the provision of healthcare services. We acknowledge that rural is flexible and adaptable. One of the prime examples that was brought up was the Health Improvement Innovation Network, so the HIN, and the idea that these rural hospitals have been able to adapt and evolve and respond to health needs and really drive some of those improvements that for a long time, they kind of were seen as an offset within that. But those hospitals and those communities around them have been able to demonstrate and prove that. We acknowledge there's changing demographics, and as much of a challenge as that may be, it's also an asset. We're seeing smaller rural communities that have more diversity within their communities. We're seeing changing demographics as far as age. And we're also looking at folks that have been originally coming from rural communities versus they are moving intentionally and by choice out to those rural communities. Desirable and community workforce. That was something that was unique that I think was called out that some folks weren't kind of expecting, but really identifying that in the rural community, I think we all kind of, being familiar with it, take for granted that we all wear multiple hats. But that really factors into having a well-educated workforce and a workforce that has a diverse skill set that is an asset to making sure, again, when you're looking at all those different working pieces within the rural healthcare system, that you have that workforce that understands the bigger picture and is often worked within that. And we also called out Okay, how about now? It keeps switching us back and forth from mute to unmute. So I really appreciate you guys in the chat box letting us know when you can hear us. Yay, okay, thank you guys. Yep, so, and it should still be recording. We're double checking that before we jump back in again. Yep, so it's still being recorded. So for those that are listening in on the recording, thanks again for sticking with us. So we'll go ahead and continue on. So again, we're just going through kind of a highlight of what the forum has been. And this is, again, why we're spitting the detail here, is because it really informs what's encapsulated within the forum summary document. So assets and attributes, we've discussed those. So challenges and barriers. We could not talk about rural health and the rural health of tomorrow in our challenge without talking about access. The access, whether that be the physical access, whether it be the availability of the workforce, whether, again, we talked, mental health was an example that we used when we talked about specialty care providers, including endocrinology. Access is a key component of challenges and barriers for a lot of our discussion. We talked about current payment and reimbursement rates and structures, including the low reimbursement rate for Iowa physicians and allied healthcare providers. We talked about the changing structures for value-based care and their implications towards rural, particularly critical access hospitals, and a lot of those health systems with low ends that can't meet those leverage points. We talked about greater economic contraction in rural areas, where a lot of small towns where we see bigger groups where they're going out for urbanization and seeking out metropolitan areas, where when those mom and pop shops kind of break down and when that contraction happens, there's not a lot of opportunity to switch that out and for reinvestment in those areas. It takes longer to build that back up. We talked again, changing demographics. As it's an asset, it's also a challenge. We also have an aging population within the state of Iowa, and a lot of our aging Iowans are wanting to move back home, and sometimes that means they're moving back home to rural where there's not as many or as convenient of access points and the spectrum of services offered in some of their communities and what that means for their long-term health. Consumer expectations and the changes around those. Again, we talk about healthcare as a commodity and the expectations of patients, the expectations of communities on their healthcare system. Again, kind of building up that conversation around the hub. We talked about the changing expectations for immediacy in their access, or is the access of a convenience willing to drive further away? And so again, those changing pieces and the need to continue to be on top of those. We talked about the lack of quote unquote core specialty services, those ones that are deemed to be closest to primary care and those immediate need responses. Workforce recruitment and retention, again, is one of those key pieces as we see a lot of our residency programs. We have about 7 to 8 in the state, and we see about 22% of those providers, particularly for physicians, as just one example, that remain in the state of Iowa, and many who may go to other states for greater economic opportunities, or maybe looking for more urban and rural settings that are placed there. We talked about the capacity to address social determinants of health, which is a key component. A lot of our conversations focus on that whole person aspect, and I think that was one of the really cool things that we saw throughout our discussions was not just a focused loci on just health. Any conversation that we had about health, healthcare service delivery, all of those pieces factored back in to that whole person perspective, whether we were talking about our patients and community or we were talking about our healthcare providers. And then we also identified that change culture, which is something that isn't just distinct to rural, but it's really impactful to rural as we look at the fact that it's changing along the way. Kind of that golden age capacity where we want to go back to the way things used to be, and that's when the best opportunity was. And so a lot of times when we're looking at this transformation and what it takes to change over time, it's that culture of change management, but also the willingness to be part of that change. Rather than sticking where we are because it's what we've known, it's how we've always done it. And we did call that out as a challenge and a barrier and an opportunity for further discussion and another resource add. And then visions for the future. The biggest thing when we looked through this is we talked about the fact that it will look different. We acknowledge that it's changing, that it's not going to be the status quo, and that we don't want it to be. That there are great things that we want to maintain, but there are also opportunities that we can continue to improve. And systems-based approaches, we acknowledge it cannot happen in a silo. It cannot happen in a one-off. and that we want it to be something that is integrated, sustainable, and forward-moving. So what is needed and the priorities? Greater awareness and understanding of existing resources, services, and rural initiatives. As we look through those pieces, one of the things that we came up with and that you'll see reflected in the discussion around the forum summary is really about sometimes we don't even know what we currently have. We might have investments in our community. We might have improvement initiatives. We may have public health services that we're not accessing or forwarding our patients onto because we don't know that they exist and how to access them. So again, recognizing we need more of that and it is a priority. We can't develop where we want to go without fully knowing what we currently have. Payment redesign that is applicable to rural health. That was a large portion of many conversations, acknowledging that a lot of the healthcare transformation that's occurring now has limited applicability to a lot of our rural communities and healthcare services due to, again, the payment structure, the methods that go through those different pieces. And we really need to make sure that rural is included in those processes, kind of building off a nothing about me without me kind of model where we need to be champions, we need to be advocates, and we need to be engaged and active in those processes. Redefining what access means was another priority of having that conversation of, does that mean that everything that I need is right there available in my one community, or does that mean that it's a network and it's a system regionally? We talked about the definitions around a critical access hospital and what that means for the future when we look at design. Transparency was another key factor, particularly when we talked about system-based approaches, and especially within our payer communities, acknowledging that oftentimes we have a lack in access to data, particularly beyond our own immediate data sets that really allow us to better understand our population and to better partner to coordinate services, particularly looking at population health and value-based care services. We talked about integration, again, those system-based approaches and that true integration among partners rather than just kind of that warm handoff where we hand that off and then it's passed along and the baton is just run the other way. It's really this integrated, reciprocal kind of symbiotic relationship. We also acknowledge technology and the burdens that come within the lack of bandwidth within our rural communities, particularly when we're talking about the opportunities to address access gaps and barriers and things along that line, where even telemedicine comes into play in a lot of our rural communities where the internet connection isn't there, the technology infrastructure is very expensive to invest in, and there currently aren't a lot of, there's incentivization, but there's not a lot of upfront investment dollars available for those smaller rural healthcare entities to really make those shifts and change. But we acknowledge that technology is not only a need, but it's also part of the future. We looked at workforce opportunity, and we talked about it not just in terms of physician retention or our pharmacies. We also talked about it in terms of our direct care workforce providers, of dental services, of public health, and what that really looks like when we talk about integrated systems of care. We also talked about what that looks like beyond just having someone come for a few short years, but really when one of our healthcare providers is an invested and long-term member of that rural community and that healthcare system. We talked about policy changes. We spent time going through and talking about some of these large-scale pieces that come into play, require policy action. Policy influences us and is part of some of the challenges, but is also part of that opportunity where, again, we can do large-scale changes that really support and reinforce improvement and sustainability in rural communities. And again, culture change. So we talked about those needs and those special skill sets that go into when you're not only going through the processes of change, but you're managing that. And that continuous change that happens, continuous transformation, and recognizing that the days of it's going to be this way and that's what it's going to look like for 30 years are most likely over. It is going to be a constant evolution and what that means to be part of that change and have that be progressing. So some of the common conclusions and the themes, when you looked across, not only when we were together that first morning and we were looking at policy and those pieces, but really when we were looking at those discussion points, the conversations that were happening across tables and throughout those rooms really looked at the idea that rural health and rural communities are diverse. We really challenged the idea that it was just going to be this Norman Rockwell picture of that's what rural looks like, and to say no, it's really diverse. Each community, there's common attributes of a Main Street mentality and some of those different pieces when we envision rural, but it's really diverse, and we have a lot of opportunities and assets that we can build upon. We also acknowledge that rural health is complex. So again, it's not as simple as it seems. Again, when we look at the idea where common misconception that because it's rural that it's cheaper, no, the delivery of care in rural can be very complex and can be costly, but it's adaptable. We're able, because of those smaller systems and because of a lot of those relationships that people have already existing, we're able to adapt and work together and be part of that change. And we've demonstrated that before. We also recognize that rural is changing. Again, that constant theme, that it is constant transformation. We're on that learning curve, and we're on the cusp of that change. Rural payment systems need to represent rural. So again, I don't want to downplay the conversations that we had around payment redesign and about payment systems. And so really making sure that we called that out. That was a common conclusion. All three groups had it. All three groups spent a substantial amount of time talking through those pieces, identifying what some of those challenges are, but then even brainstorming around what are some of those different pieces that could be in play, and or how do we advocate? How do we make sure we have a seat at the table? And another common theme was the need for rural leaders, stakeholders, and advocates to be part of that change. So again, how do we make sure that we have a seat at the table? How do we make sure that we are informing these conversations around what's happening in rural? And for myself as a patient advocate and PFE champion, I really likened it to what I was hearing was, again, that nothing about me without me. So how do we invest and partner and be part of that, and not just be recipients or not just be reactive, but really be proactive? So at the end of our forum, again, were these leadership reactions. And I think one of the cool things that we had when we went throughout this, not only do we have leadership reactions, so it wasn't just something where the three groups reported out and a leadership reacted on their own, but it was really an integrated process where our leaders were there, Dr. Evans, Director Claybaugh, Chris Atchison, Keith Mueller, and then of course the leaders of our health system. So all of you were all in those rooms, had those responses, and when we did leadership reactions, here's some of the highlights, but I really want to call out the fact that it really wasn't a didactic component, it was really conversational, and I think that's something that really stood out about the Rural Health Forum, and I think it also exemplified that culture of rural and relationships that we have been talking about for the past 2 days. So a couple of those reactions that stood out were, again, and a lot of this hones in and further supports and confirms some of those conversations we were having, is that rural health is and can be nimble and adaptive. That is an opportunity for us, and that is also one of our strengths that we have. We're willing to be part of the change, even though sometimes we don't exactly know how, but that willingness is there, and we can start moving now. We don't have to wait until there's some large, major piece, that we can start making small-scale changes that build up towards that, and also be part of those larger initiatives such as federal improvement initiatives or policy changes, things along that line. We also called out the recognition of a need to identify and address root causes. That oftentimes when we talk about healthcare transformation, whether it be in urban settings or in rural, we often talk about sometimes what the symptoms are, but we don't always get down to a root cause of what's occurring. So the intention and the need to really be strategic and deliver about how we get down to the root cause, so that way when we are investing our time, energy, and resources, that we're connecting in on those actual causes that are going to have the greatest impact when we address them. The complexities and challenges of rural are not new. Again, reminding ourselves that this has been part of that constant, that this isn't a brand new piece that's there. So even though we feel like it may be new and it's constantly emerging, no, we've been part of this to go, so we have that skill set. And that continuous transformation is actually a part of what makes rural rural. And challenges and opportunity to come together and work together. So really that positive aspect that we had from our forum is that it wasn't something where we were just talking about what's wrong, I want to tell someone, and then we felt like we were walking away. But we really had an atmosphere of wanting to be part of that change, and that with that challenge is this opportunity for partners who maybe haven't worked together or haven't worked together as closely to really come together and be actionable in how they partner. The connections and relationships are the hallmark of rural that was consistent throughout all of our conversations. The rural perspective is changing from a town focus to broader service areas. So again, that systems-based approach, then that's where our change must be focused. So again, you see this kind of guiding through, and when we lead through that is, again, our conversations always kind of went towards those common themes. So you see that consistency not only in leadership reactions, but in each of those individual discussion conversations that we're having. And our recommendations to advance rural health in Iowa. 3 of our primary recommendations that we had within rural health was to reassess and reaffirm. A core component of that, again, we talked about, we need to know what we currently have. We need to be going through and looking at truly what is rural right now. What structures do we have? What resources do we have? What does it currently look like? What do we currently need? What factors into those different pieces? And then redefine. We need to be looking at, again, that change culture to say, what does access mean? What does it mean to be a critical access hospital? What does it mean to be a rural healthcare provider? What does it mean to be a rural community? Redefining what those pieces mean and the ways that we're going to apply and address them. And those pieces of knowing better of what we have, what it looks like, what are our assets, what are our opportunities, what truly are our root cause barriers, and then being willing to redefine and look at what has been, what could be, what should be, leading into that redesign. We recognize, again, that it is changing, that it's going to look different, that we're going to have to redesign our systems. We're going to have to redesign some of our ways of interacting and doing things, redesign and reevaluate some of our expectations. And so being part of that change and having that continuous conversation and looking at those roles and responsibilities and what that looks like and what each one of us can do through that process across the spectrum. Again, one of the reasons why for our forum, we wanted to ensure that we had multiple disciplines, multiple settings throughout the state of Iowa present. So the proposed next steps. So one of the things that was really great about our forum and that I like to call out, and I want to commend all of our forum attendees on, is that none of us came to the forum, again, with the expectation that we were just going to speak out and then walk away. Every single person who was in attendance talked about the desire of what happens next. What is the action step? What does this lead to? So the proposed next steps, again, and this is an encapsulation of what our discussion and what our groups and attendees decided on that last day of our forum. We talked about creating an environmental scan and inventory. So again, what do we currently have? We are reassessing, reaffirming. We're looking at rural health services and resources. What are those gaps and opportunities to collaborate? We want to continue the conversations. Again, we want to continue the conversations that happened at our forum. We talked also about previous symposium activities, but we talked about all of the learning that happened just from being able to be present around with one another and share our different perspectives, to talk about the different resources that we had. And that we want to be, again, we want to be at that table. We want to be part of the change. So how do we co-design solutions? So again, that we are making optimal use of resources and investments by not just saying, well, in this silo, we're going to work on a fix here, and this silo, we're going to work on a fix there. And really, we're duplicating within those wheels, or we're not aligning where we could be, and we're not actually building sustainable systems-based approaches. So we want to co-design those solutions, and we want to expand the network. So again, not just expanding the network, where earlier in our conversation I talked about who else would be present, who all was there, but really looking at even our rural health networks. What do our system-based approaches look like? And then from that conversation, we came down, we said, we would like to reconvene a forum or a summit. We'd like to have another opportunity to get us all together in a room to be able to have conversations like this. A lot of the feedback that we heard throughout the day was really around the idea that often we might know the other people in the room, but we don't get a chance to really sit down and go through those conversations and get into some of those details, to get to some of those nuances, to talk about some of those root causes that sometimes even when we try, it can't happen in a 1-hour webinar, even if we have them routinely, but sometimes there's just value in having set aside time to sit down together, go through those pieces, and have uninterrupted time to discuss with one another. And then we also wanted to look at investigating and promoting staged approaches and models for rural. So again, these next steps are not these far-flung ideas that we had, but really looking at more immediate responses that we could have from our forum. So looking at what others are doing, what are the best practices, what are the emerging models, what are those practical applications? What can we take from what others are doing? As an example, we talked about the Pennsylvania model, where they're going through and looking at multi-payer, single-payer global budgeting that happens in rural communities. Again, bringing everybody to kind of a level playing field and working through those pieces. What does that look like for them? What are some of those really good lessons learned? What are some of those opportunities? How would we adapt that? So again, recognizing we don't necessarily want to or need to reinvent the wheel, but how can we go through that? And again, not just try to go from 0 to 60, as we mentioned, but that continuous change. So how are we adaptable? How do we take this step by step? So, and the nice thing too, as we went through this, is that a lot of the conversations that we have within that are not just, and this is kind of a note that we talked about with Ashley, and I really appreciate you calling out the Pennsylvania model, really being in its infancy stages. And that is something that we acknowledged and called out as part of that forum. And I think when we talked about that, and the reason why I brought that up as an example, is really looking at the opportunity to be part of that learning curve with folks. And to be mindful and watching what others are doing, and not waiting until an end stage, say, oh, we're going to wait until it's fully adaptable. Now, we may not take their pieces and use it just yet, but one of the conversations that we had, I know when we were doing our debrief, and I know, Ashley, you were there for some of the earlier parts, was just the opportunity to keep an eye on what's there. What are the small pieces? What are those promising practices? So I really appreciate you calling that out, Ashley. Thank you. So a complete summary. So we just went through and we talked through the entire forum event. And the reason when we kind of go through that we went through that detail is, again, that is what informed the summary. When you look through the summary is going to encapsulate those pieces. So the summary that was sent to you guys as we went through, and the link to the summary, we actually didn't link it to you, we just sent it to you in an actual PDF version, so then that way you guys were able to review and scroll through on your own. But it's the summary report to promote action. So the first next step to our follow-up, again, if you remember from that last day where we talked about, so what do we do next? And we said we're going to pull together a summary. And we first intended it just to be kind of a quick report. And so we thought we would be able to get it done earlier in the year, around January, February. But when we kind of got into it a little bit deeper and we were really wanting to keep with the intention and the attitude of the forum of not just having something out there, but really how do we keep propelling this forward, we wanted to take a little bit more time, be a bit more intentional, and go a little bit more in depth in order to provide that comprehensive review in detail. And really, when you look through the summary form, as you guys are kind of filtering through, it's intended to be something that is that document that can be picked up by anyone, and really they're going to understand what's happening. So you'll be able to get the introduction of the current landscape, the background and the overview again of those priorities, but then that complete outline of the full detail of the form. So again, so we had so many people that weren't present, weren't able to join us. And so making sure that if they were to pick up this summary, they would be able to read through, get up to speed a bit with us, and really actively engage in those continuing conversations. So as we expand our networks and we expand our activities, that again, we have a resource to bring people along with us. So this is where we've been on mute so far, and we've gone through all of the different pieces and kind of scrolled through with everything as we were going through. But what I'd like to do is I'd like to take everybody off mute. So I would encourage you guys to go ahead and if you want to mute yourself on your side and unmute yourself when you want to speak, or if you want to stay muted and enter your information to the chat box. This is really, again, the document is ours. The summary report form is our document. It's co-owned. It's part of all of the forum attendees that are there. So I want to give you guys a chance to get your review and feedback on there. So give me just a second. I'm going to unmute everybody. Okay, so everybody should be unmuted. So again, if you want to go ahead, just a second, we've got some feedback here. All right, there we go, that's better. So reactions and feedback. So first what I'd like to do is kind of get your guys' thoughts and feedback to the forum. So the actual event that we held back in December, what has been your experience in learning from the event? So what did you guys think of the actual forum event? And then also if you guys want to share any actions or efforts that maybe the forum spurred for us, maybe something that we've done since that point. And I've talked a whole lot. I could keep talking and go through and share some of those other pieces from our side, but I'd really like to hear from you guys.
Katie, this is Ashley. Can you hear me?
I can. Hi, Ash.
Hi there. So just first, I wanted to say a really nice job pulling together this summary. I think this is really helpful. I'm glad that, you know, we've been able to see the fruits of your labor and the outcomes of our forum from December. And I think much of what you touched on, you know, I see Dr. Mueller and some other folks are here, you know, whether it's Roofery or the health systems or member associations, I think we're all continuing to focus on a number of strategies, initiatives, programs, services that are focused on rural. I think maybe, you know, a lot of what you've talked about today, you know, health systems like UniPoint Health, I don't think we're alone in focusing on a lot of what you covered. I think what I maybe am struggling with, and maybe you can help me understand, so, you know, we held this forum, and I think it was, you know, sort of a first opportunity, and, you know, there are other types of forums that I think happen throughout the state to, you know, bring health systems and associations and providers and groups together to talk about things. I guess I'm sort of struggling. I feel like this is another kind of, you know, group that we've convened and pulled everyone together, but I'm struggling maybe a bit with the purpose. So, you know, whether it's looking at value-based care models or things like that, is really the intent of this is to bring folks together and see if we might work together on something. I guess maybe help me understand the larger purpose of this.
Yeah, thanks, Ashley. So that was one of actually the thoughts around, and I'm going to go ahead and just as I respond, because we've got some background, I'm going to mute again, and then I'll unmute for everybody. Was really when we were convening this together, that was one of my questions. What's the purpose of this? Is this going Okay, can you guys hear me again now? Perfect, thanks. So it appears that there might be some sort of a glitch with when you go to mute something that it actually hangs me up. So if I'm supposed to be muted, you don't need to be on the call. So apologies for that, guys. But Ashley, I'm really glad you brought that up, because what I was saying was that was actually one of my thoughts before we convene this. Is saying, okay, we can get people together, we can get a vision, but what are we going to do with it? What's the intention? What's the next step from that? And I think from that, it's kind of a multi-tier approach. So for one thing, I think one of the things that came from this that I think that we got leadership, investment, and buy-in to do, but they haven't been quite sure exactly what does that look like just yet. Is it just another form? How do we use some of those different pieces? But with the intention to say, okay, this can be a body that can really move this forward. So do we reconvene this as we're going through those different pieces? And so yes, IDPH, IHC, and others. So again, that initial part of that leadership to where this group can become a rural health leadership group. To say, we bridge it together, what does that look like? But specifically around some of the work that IHC does with some of the federal initiatives that are touching a vast majority of the health systems in some capacity, but also Department of Public Health, particularly with some of the State Office of Rural Health funding and those targeted and intentional dollars that come down to the state, that this forum and this document can really be used to inform. So again, when we're going through and saying, what does it look like if we're going to be doing a flex program model, or if CMS is asking us for what rural looks like, that here's this consensus and here's what that looks like. And then the next tier for that, again, is to look at those pieces that each one of us do. So as an example, for IHC, so again, one of the leadership conveners that were there, but also looking at the CMS innovation models that are happening. When we're looking through and we are responding and looking to address and tailor those things for rural communities, what does it really look like? Having an understanding of that beyond our own understanding, which I know from Tom when he was there, where, you know, his quote was, my mind's blown of just, you know, we know what we know really well, but we don't know all of that. So I think the intention, the purpose of that was multi-tier. So really having this to where informed not only how we advocate at the federal and state level, but then also being able to have that inform our programming on that. But really when it comes together on the specifics around, is it going to be value-based purchasing? Is it going to be that? I think part of that is still in determination, to be frank and honest with you. I know there's ongoing conversations that they're having, and I think part of, for us, is to know, so one of the next steps that our group identified was they wanted to have a forum or a symposium. So if we were to convene that, we as like the large scale of us as the forum folks, what would that look like? What would need to be there? Is that when we would prioritize and say, okay, the big conversation that we need and want to have right now is value-based purchasing, is something else that's in there. So I think part of that, without, again, having kind of, to be honest, Ash, that murky purpose, is the opportunity for us as a whole group to really, again, be the voice at that table and say, this is what we want it to be. This is what it could be. So rather than even us looking at it as reaction, I think there's an opportunity for us to say, and that's what I would put, that's how I view it for myself, and how I encourage everyone else to look at it. So I don't know if that's as helpful on there, but just kind of acknowledging the multi-tier intention to start with, and that the fact that there's still some gray. So I'm muting everyone again. So. Did that help at all? Did I answer your question, or did it just kind of ring around?
No, I think it answered it. I mean, clearly, I think there's still a lot left to determine. I know I'm not alone in this. I continue to struggle with, you know, looking at value-based purchasing and CMS Innovation Center opportunities. You know, health systems are, you know, be it Mercy or Unity Point or Genesis or UIHC. I mean, we're all looking at those opportunities. I know IHC obviously continues to pursue opportunities at the CMS and HHS level for funding to do things like SIM and TCPI. And there's just a lot of, there's a lot of groups. I mean, you know, RUPRI is doing a lot of sort of research. There's policy and advocacy groups. There's association groups. So I'm just trying to wrap my mind around, is IDPH and IHC, are you trying to convene all of these groups and to get kind of collective consensus that we might do something like I'm making this up, but like a Pennsylvania type model? I'm still just, I mean, I think it's a great opportunity to bring folks together for a forum or a summit, but I'm trying to get to, is there a greater strategy or a goal here to get us to move just something else other than just talking about rural health. And I mean, you know, there's tons of definitions around rural health, whether it's HPSAs or, you know, things that we have to follow on a federal or a state perspective for funding or other things like that. I'm trying to understand, are we reinventing the wheel here, or is there larger goals and strategies that we're going after grant funding, or trying to make some systemic changes in value-based care in the state?
Yeah, and I think from my perspective is that we're working towards those bigger goals and trying to figure out exactly what that looks like and what it could be. Kind of that first stage of that reaffirm and reassess, to say, okay, what do we have? What could we do? What should we be doing? And then, Chris, I really appreciate in the chat group where you talked about many entities are acting. This is a good overview, but an effort to assign leads to those systems. I think that has to be part of that next step, is to say, okay, so as we go through that and we figure out what could those goals be, should we be going towards those bigger pieces, Ashley, like you mentioned. And then it comes into that whole point of saying, okay, so now that we've assessed it, we're aware, what's the role and responsibility? Where do people come into that point, and how do we assign those things? And I think that's part of the continuation of this group and of the report.
So Katie, this is Ashley again. Sorry to kind of take over the call, but maybe that would be something that you can communicate to Gerd and Tom and others. I think something we'll need to get clear on, and I think really to get buy-in from executive leadership level. So, you know, the Kevin Vermeers and Bob Ritz's and, you know, IME leadership and all of that. You know, I think this is all great and good networking and discussion around everything that we're doing. I think that's critical. But if we're looking at moving anything forward from a state perspective, I think we need to get maybe a little bit clear on what it is this group is being asked to do.
Thanks, Ashley. Yeah, and that's part of also with having the follow-up for this, is to recapture and say, okay, are we also invested, or do we still all want to sit at the table, what that looks like? And so this will be stuff that's fed back to, you know, all of those folks that you had just mentioned, to kind of say, okay, do we have the buy-in? Can we move this forward? And really getting kind of that gumption to go type of thing. So thanks, Ashley. And we've got about 5 minutes left. I want to be mindful of everybody's time too. So I also want to open it up to folks to have any thoughts from even the summary as you review it and you look at the document. Do you feel it adequately captures the discussion and themes? Are there opportunities, again, that you see for using and sharing? I know we kind of go through, and once we have the updated, any feedback from you guys too, like, again, I know we mentioned there were a couple different typos that people caught, which I'm always super thankful for the multitude of eyes after you've looked at a document so many times. Sometimes it just goes blank for you. That it will be publicly available, so it'll be open for us to share among each other and then also with our stakeholder network. So any other thoughts or comments from anyone?
Katie?
Julie, I want to acknowledge, go ahead.
Yeah, Katie, this is Chris. Just one other thing, and I hope I express it well. I'm kind of thinking that there's maybe needs a little more focus from the patient side up. The rural communities are diverse, and we say a lot of that stuff, but we kind of are looking at it from the top down, that there need to be systems within the community. One of the nuances of that is the identification of how patient needs may vary community by community, and to have that system in place. And again, I don't know if I'm expressing it right, but I wanted to kind of flip the equation on its head and think about, how, if you've got some type of production facility within one rural community and another doesn't have it, you may have different issues in terms of the individual patient need. And so the variety of providers, the expertise that would be needed in one community could differ from community to community. And then having kind of an inventory that responds to those individual patient needs, I think is really critical. Again, I think we come at it from the top down and maybe not enough from the bottom up.
Chris, I love that you brought up the patient perspective. I saw a lot of thumbs up for people who also had their webcams on that were on there. That was actually a note that I had from when we were actually at the forum, that we had a lot of conversation about our patients and about our communities, but not as much representation directly from them. So that was one of the things that I had identified of saying, okay, what are those next things that we carry out to those groups? And we look at those different pieces, particularly looking at the patient side perspective, as you mentioned. So I appreciate you really calling that out, and I've kind of made notes for that as we look towards those next steps. So anyone else who'd like, I know we had we have quite a few different people that are on there, some folks that were present, some that were not. Okay. All right, well, I want to be very mindful of everyone's time, so we're sitting at 2:59 now. So number one, thank you guys very much. Really appreciate you guys taking an hour of your day coming back together around this. Again, the intention, I believe from this is that this is going to be just that next step, that we're going to move those things forward. So we've taken notes from what we've heard from people for feedback. And then I would encourage and welcome you guys over this next week. Again, if you get a chance to dive a little bit deeper into the summary, or you look through some of those different pieces, reach out to me, share some of those different pieces. I'm going to be helping to compile some of the reactions that we had from this that we can share with, again, that quote unquote, the leadership groups that we have, and then the expansion of that that we've called out from that point of view, and then kind of leading from that next piece. So, and then once everything, again, once we got the recording, again, minus that first piece, really appreciate you guys sticking around for all the technical difficulties, but we'll have the recording available. And then, of course, the slide deck also will be available as well, so that you can have that for yourself. So we will be sending that out to you guys ASAP, so hopefully still yet within this week, so by Friday. So, but thank you guys. Reach out if you have any other questions. I'll look forward to hearing and having more conversations, but hope you all have a great rest of your afternoon.